All right, ready to untangle a bit of a medical coding mystery. We're doing a deep dive today into coding acute myocardial infarctions, or
Mhm.
AMIs. You know,
Oh, yeah. AMIs, they can definitely be tricky.
they really can. So if you've got your notes and that AMCI Medical Coding Guidelines MCG Manual handy, the one we've got linked in the description, by the
Let's
way,
definitely grab that.
it might feel a little bit like you're trying to decipher some ancient language.
Oh, absolutely. Like medical hieroglyphics.
But don't worry, we're going to break it all down.
Yeah, we'll make sense of it all.
We'll look at the different types of AMIs and those very specific rules for how we code them.
Yeah, and I think it's important to remember that, getting the coding right for AMIs, it's not just about the paperwork. It has a real impact on patient care and,
Oh, yeah, for sure. Reimbursements.
reimbursements. Yeah,
Mm.
absolutely. It can feel a bit overwhelming, but I promise we'll break it down step by step. And by the end of this deep dive, you'll be navigating those AMCI guidelines like a pro.
Absolutely. You'll be a master of the flip and tap methods. But before we get ahead of ourselves, let's start with the basics. We hear STEMI and STEMI all the time.
Right.
But what do those even mean?
Yeah, it's more than just acronyms,
Wow.
right? So, think of it this way. A STEMI, which is short for ST elevation myocardial infarction, that's
Hmm.
like a major traffic jam in a critical artery of the heart.
Oh, okay.
Blood flow is completely blocked, and that's a serious situation, medical emergency.
Gotcha.
Then you've got your NSTEMI, non-ST elevation myocardial infarction. Think of that more like a fender bender.
Okay.
There's still some blockage and reduced blood flow, but it's not as immediately life-threatening as that major traffic jam we talked about with the STEMI.
Interesting. So it's like levels of blockage, kind of?
Exactly.
Okay.
Different degrees of severity.
So then how do the guidelines differentiate between those two when it comes to
Yeah.
coding? Because, I mean,
That's where it gets really interesting. The AMCI guidelines, and specifically you'll find this in that MCG manual we mentioned, they lay out very specific directions on how to code both STEMIs and NSTEMIs. And get this, they even take into account those situations where, say, an NSTEMI might progress and actually turn into a STEMI.
oh, wow.
Or even the other way around, that's where clear documentation is absolutely crucial.
So we're talking about more than just picking a code for STEMI or NSTEMI. We're looking at like how the problem changes over time.
Precisely, you've got it. And speaking of time, that brings us to the infamous 4-week rule.
Oh, yes, the 4-week rule. I've heard coders whisper about this one in hushed tones.
It's a big one.
Why is this 4-week time frame so important when we're coding these AMIs?
Well, it all comes down to how we classify and code those encounters that happen after the initial AMI. Think of it like this. Anything that happens within 4 weeks of that initial AMI, whether it's a transfer to another facility, a complication, maybe even just a routine follow-up visit, all of that, it falls under a different set of codes. Then encounters that occur after that 4-week period. That's the dividing line.
So to give an example, let's say a patient's hospitalized for a STEMI,
Right.
and then like a week later they get transferred to a rehab facility.
Okay, yeah.
That transfer, that would be coded differently than if it happens, say, 6 weeks after that first AMI.
You got it. That's exactly right. And the documentation needs to clearly show the time frame so we can choose the right code. Because remember, we're not just coding the AMI itself, we're coding the whole patient journey that's related to that AMI.
Okay, that makes a lot of sense. But what about those situations where the documentation isn't so clear? Say a patient's chart just says AMI,
Uh-huh.
but doesn't specify STEMI or NSTEMI, what do we do then?
The mystery diagnosis.
Right.
Well, that's where code I21.9 comes in.
Okay.
It's our catch-all for an unspecified AMI type. But here's the thing. Even if the documentation is a little vague, you still have to put on your detective hat.
Oh, okay, I like that.
Yeah, right. Look for any clues in those clinical notes, lab results, imaging reports, anything that might point you towards a more specific type of AMI. Don't just settle for unspecified if you can help it.
So even when it seems straightforward, there's still some detective work.
Always. It's all about finding the most accurate code possible. And, sometimes you might even see STEMI or transmural MI documented,
Mm-hmm.
but without a specific location. In those cases, I21.3, that's your go-to code.
Okay, so we've got the initial AMI encounter, and we've tackled those unspecified cases. But what happens when a patient has multiple AMIs within that critical 4-week window? Because that's going to complicate things even further, right?
Oh, absolutely. You're talking about a whole other layer of complexity, and that's where those category I22 codes come into play.
Okay.
So if a patient has a new AMI and it's within 4 weeks of a previous type 1 or unspecified AMI, we use a code from I22 along with the appropriate code from I21 to really capture the full picture of what's going on.
So we're basically using multiple codes to tell the whole story.
Exactly, like building blocks, layering them to paint a complete picture. But hold on, don't go slapping an I22 code on every time a patient has a repeat AMI within 4 weeks. The guidelines are very clear about when those codes apply, and we have to follow those rules. For example, you wouldn't use an I22 code for a subsequent type 2 AMI.
Wait, hold on. We haven't even talked about type 2 AMIs yet. It seems like each type of AMI has its own unique code.
You're right, it's like each one has its own fingerprint.
So walk me through these different AMI fingerprints, if you will. We talked about type 1, which includes STEMI and NSTEMI. But what about these mysterious type 2 AMIs?
All right, let's unlock the mystery of type 2 AMIs. They're coded as I21.A1, and they're a bit different. Instead of that blockage we see in type 1 AMIs, type 2 is usually about an imbalance between the heart's oxygen supply and demand. It's like the heart's working overtime, but not getting enough fuel to keep up.
It's not necessarily a blockage, but still a problem with blood flow.
Exactly. And here's the thing. When we code those type 2 AMIs, we often have to code the underlying cause too, like, coronary artery spasm, or maybe even something like severe anemia. This helps us paint that full clinical picture, ensuring the patient gets the right treatment.
It sounds like coding type 2 AMIs really requires us to dig deep into the patient's history, understand what's going on.
You got it. And keep in mind, there are some restrictions when you're coding type 2 AMIs. For example, you wouldn't use code I24.89 for something called demand ischemia.
Demand ischemia, that sounds pretty intense.
It is. Basically, it's when the heart muscle isn't getting enough oxygen-rich blood because the demand for oxygen is way higher than the supply. Think of it like maybe strenuous exercise or even intense emotional stress.
So it's like the heart's trying to sprint a marathon.
Perfect analogy. Now, another key point about type 2 AMIs, if it's documented as either NSTEMI or STEMI, we stick with that code, I21.A1 only. We don't add an extra code for the type 1 AMI.
So it's all about the specifics, huh?
Absolutely. We're not just coding the AMI, we're coding the whole situation surrounding it. And this level of detail, it becomes even more important when we start talking about complications.
Right. What happens when things get even more complex, like a patient develops a post-procedural AMI, maybe after an angioplasty? How do we handle that in the coding?
That's when we rely on those code also and code first notes in the MCG manual. They guide us on how to sequence the codes correctly. We capture both the initial AMI and then that added complication.
So it's like a choose-your-own-adventure, but for medical coding. Each decision leads to a different code.
I like that. And sometimes those paths lead us to some unexpected places, especially when we're dealing with less common conditions like myocardial infarction with coronary microvascular dysfunction. We call it CMD for short.
CMD. Okay, that one sounds like a real brain twister. Break it down for me.
So imagine those tiny capillaries in your heart, the tiniest blood vessels, the ones that deliver the oxygen and nutrients to your heart muscle. Now imagine those capillaries getting messed up, disrupting the blood flow and causing damage to the heart. That's essentially what CMD is.
So like a traffic jam, but in the heart's back roads.
Exactly. And that's where things get really interesting from a coding perspective. CMD throws a bit of a curveball because it often doesn't present with those classic signs of a blockage in the larger arteries.
So we can't just rely on the typical STEMI or NSTEMI criteria.
Right. We have to look for more specific clues, like, signs of microvascular dysfunction on those specialized imaging tests, or maybe unusual blood flow patterns in the heart.
It sounds like coding for CMD really takes a deeper understanding of the clinical stuff and those diagnostic tools.
You're absolutely right. It emphasizes just how important it is to stay updated with the latest research, those new advancements in cardiac imaging. It all has a direct impact on how we code these more complex cases.
I have to say, all this is fascinating, but I'm realizing we've just scratched the surface of AMI coding here.
We have, but don't worry, there's so much more to explore. It's amazing how far we've come in cardiology, right? We can diagnose and treat things now that, years ago would have been, impossible to even see.
Absolutely. And as these advancements keep coming, it affects coding too, right? We have to keep up with all the changes.
Exactly. Coding has to evolve along with healthcare. And that brings us back to those flip and tap methods we mentioned before. They're super helpful when it comes to those ICD-10-CM guidelines. especially for AMIs.
Right. Okay, remind me again, what are those flip and tap methods all about? They sound like kind of secret.
You like your secret weapons for coding, really.
Yeah.
So the flick section in the MCG manual, that's medical coding guidelines, it gives you a clear interpretation of the official ICD-10-CM guidelines. It's like, think of it as your cheat sheet, you know?
Okay.
Helps you understand the main ideas and find your way through those big, thick coding manuals.
So flip is about simplifying those guidelines.
Exactly. It takes all that complicated coding language and makes it, makes sense. And then we have the TAP method. That stands for tab, annotate, and place.
Tab, annotate, place. Okay, break that down for me.
It's a really easy way to add notes and reminders right into your ICD-10-CM manual. First you tab to the right page in your manual, then you annotate that guideline with extra insights and tips from the MCG manual. And finally, you place the word TAP right next to the code in the tabular list. It's a visual cue.
So we're like making our own customized coding manuals tailored to our needs.
Precisely. It's about giving ourselves the tools to code with confidence. And speaking of accuracy, we talked before about how important documentation is in coding AMIs.
Right, because if we don't have good information, the best guidelines won't help.
Exactly. The codes we choose, they rely on the documentation being clear, complete, no contradictions. If it's vague, incomplete, it makes our job a lot harder.
Absolutely. And it can impact patient care. So let's say a physician documents an AMI as non-transmural or subendocardial, but they also give a specific site. What do?
Even with the site documented, we'd still code it as a subendocardial AMI. The guidelines are pretty specific on this. The type of AMI, subendocardial in this case, it's more important than the location.
Interesting. So it's all about following the hierarchy, the logic, and the guidelines. And this brings us right back to that AMCI MCG Manual, our trusty guide for AMI coding.
Couldn't have said it better. It's like having an expert right there whispering the correct code in your ear.
And as a reminder, everyone, we have that manual linked in the description. Definitely check it out. Bookmark it, highlight it, get to know it well. It's going to be your best friend when you're coding these AMIs.
Absolutely. Now, before we wrap up our AMI coding talk, I want to circle back to something you mentioned earlier about advancements in cardiac imaging and diagnostics and how that might affect coding in the future.
Yes. I'm so glad you brought that up. It really makes you wonder, how those advancements are going to shape the coding guidelines of tomorrow. We're already seeing new imaging techniques that can pick up on subtle changes in the heart that, we couldn't even see before.
It really is incredible, isn't it? And as this technology gets even more sophisticated, our understanding of heart disease is going to grow. And that means probably more refined diagnostic criteria and, maybe even entirely new categories of AMIs.
So are you saying the future of AMI coding might involve brand new codes or even a whole restructuring of the existing codes to account for all this new information?
It's definitely a possibility. We might see new codes pop up for, these new imaging techniques. Or we might see existing codes get redefined to cover a wider range of how AMIs can show up. It's such an exciting field. Coders really need to keep learning.
Absolutely. It shows that medical coding is always evolving. We got to be adaptable, keep learning, and be curious.
I totally agree. And while we're thinking about the future, let's not forget the present. Those AMCI guidelines, especially in the MCG manual, are our map right now for coding AMIs correctly. They give us a strong foundation for accurate, ethical coding.
And even with the guidelines, it's still up to us as coders to stay informed, think critically, and apply our expertise to each specific case. We're not just assigning codes, we're telling a story.
That's a great way to put it.
Yeah, we're using codes to tell the story of a patient's heart health.
And those stories we tell, they really do have a big impact on patient care, on research, on the whole healthcare system.
Okay, I think we've covered a lot today, from the basics of AMI types to that complex CMD. We've even talked about the future. It's been a real journey.
It really has. Now, before we wrap up this deep dive, let's summarize the key points for our listeners, shall we?
All right, let's do a quick recap of everything we've talked about today with these AMIs. It's a lot more than just memorizing codes, right? It's about really understanding what's going on with each patient and using those guidelines the right way.
Absolutely. We started by talking about those main types of AMIs you see, the STEMI and the NSTEMI. Remember, those are both type 1. The STEMI, that's like the major traffic jam in the heart, and the NSTEMI, well, that's more like a fender bender. Both disrupt that blood flow, but, to different degrees.
And then, of course, we can't forget about that 4-week rule. That's the rule that, it tells us how to code those encounters that happen right after the AMI and those that happen later on. It's like kind of a dividing line in how we classify and code things.
Right. We also got into those tricky cases where the documentation is a little fuzzy. Maybe it just says AMI and doesn't say what type. That's when your coding detective skills have to come out.
Got to put on that detective hat and look for clues, right? Go through the notes, the lab results, anything that can help us figure out the most accurate code.
Exactly. And then we talked about this type 2 AMIs. Those are the ones where it's not always a blockage, but more of an imbalance between oxygen supply and demand. It's like, imagine your heart's trying to run a marathon, but only has enough energy for a quick sprint.
We learned that when we're coding type 2 AMIs, we often need to code the underlying cause, too. Things like coronary artery spasm or even anemia. We want to give a full picture of what's going on with that patient.
And then we got into that really interesting topic, that myocardial infarction with coronary microvascular dysfunction, or CMD. Remember, that's where those tiny capillaries in the heart, those little back roads, they get disrupted and mess with the blood flow.
Yeah, CMD, that one shows how those advancements in cardiac imaging are changing how we diagnose and treat heart problems, which of course affects how we code everything. It's a good reminder that this field is constantly changing.
And to keep up with those changes, those flip and tap methods from the AMCI MCG Manual, those are lifesavers. They help us navigate those sometimes confusing ICD-10-CM guidelines, especially for AMIs.
I love that idea of making our own custom coding manuals with those tap annotations. It's like we're taking charge of those guidelines and making them work for us.
It's all about giving yourself the tools to code accurately and confidently.
So to wrap things up, coding these AMIs, it's not just about assigning some numbers. It's about telling the story of a patient's heart health journey. And with what we've learned today, well, you're better equipped to tell that story with accuracy and understanding.
And as you keep learning and growing in your coding career, remember to stay curious, keep learning new things, and never stop exploring the world of cardiology and how it all ties into coding. It's a fascinating field.
Couldn't agree more.
Yeah.
Thanks for joining us for this deep dive into the world of AMI coding. We'll see you next time for another coding adventure.